Human survival rests on a single, continuous mathematical output. Every microscopic muscle fiber, every valve leaflet, and every electrical pathway in the human body exists to serve one deterministic engine. That metric is cardiac output. It is the absolute volume of blood the heart ejects into the systemic circulation every single minute. This output is defined by a rigid equation. Cardiac output equals heart rate multiplied by stroke volume. Stroke volume is the difference between end diastolic volume, the preload, and end systolic volume, the afterload. The driving force is contractility. To understand how the heart sustains continuous perfusion to the body, and to predict how it fails during ischemic events, we must construct it from first principles. We will assemble this engine step by step. We will map the physical structure, install the electrical grid, route the vascular fuel lines, and observe the system in motion. The mathematics of cardiac output only function if the physical barriers and electrical pathways of this architecture remain perfectly segregated and perfectly sequenced. We begin with the physical housing, composed of 4 distinct layers. The outer fibrous pericardium is a tough sac that prevents overfilling and anchors the heart in place. Beneath it lies the epicardium, housing the fat and coronary vessels. Inside is the myocardium, the pumping layer. And finally, the innermost boundary is the endocardium. The endocardium is a continuous, smooth endothelial lining. It provides a frictionless surface for blood flow, effectively preventing turbulence and unwanted clotting within the chambers. The myocardium does the actual physical work. It relies on specialized connections between cells called intercalated discs and DAP junctions. These structures allow electrical currents to pass rapidly from cell to cell, triggering a synchronized contraction known as a syncytial squeeze. This muscle mass is distributed unequally. The right ventricle pumps blood only to the adjacent lungs, so it features a crescent shape and a thinner wall suited for a low-pressure system. The left ventricle must generate massive systemic pressure to perfuse the entire body, requiring a thick, heavily muscular wall. The flow of fluid through these chambers follows a strict sequence. Deoxygenated blood from the body enters the right atrium through the superior and inferior vena cavae. It drops into the right ventricle, which ejects it through the pulmonic valve into the pulmonary arteries toward the lungs. After gas exchange, oxygenated blood returns via 4 pulmonary veins into the left atrium. It descends into the left ventricle and is forcefully ejected through the aortic valve to supply the systemic circulation. This continuous flow forms a closed double-circuit pump system. The right heart handles pulmonary transit, while the left heart drives systemic perfusion. This muscular loop is highly efficient, but it relies entirely on strict one-way traffic control and a rigid structural framework to endure the cyclical pressure. To enforce one-way flow during the violent contraction of systole, the heart relies on atrioventricular, or AV valves, the tricuspid on the right and the mitral on the left. These valves require specialized structural reinforcement. Muscle bundles called papillary muscles extend from the ventricular walls and connect to the valve leaflets via tough fibrous cords known as chordae tendineae. As ventricular pressure spikes during contraction, these heartstrings pull taut. They anchor the leaflets, physically preventing the valves from prolapsing backward into the atria. All 4 valves are anchored to the core structural component of the heart, the fibrous skeleton. This is a dense ring of connective tissue situated directly between the atria and the ventricles. Its primary function is mechanical. It provides a rigid mounting point for the valve rings and acts as a fixed anchor for the contracting myocardium to pull against. But the fibrous skeleton serves a hidden, equally vital secondary function. It is a total electrical insulator. It completely blocks electrical impulses from crossing randomly between the upper and lower chambers. By physically blocking stray currents, the fibrous skeleton forces all depolarizing signals to travel through a single, highly regulated physiological bottleneck, preventing chaotic arrhythmias. The electrical impulse begins high in the right atrium at the sinoatrial or SA node. This intrinsic pacemaker generates a spontaneous rhythm of 60 to 100 beats per minute, driven by the continuous influx of sodium and calcium through funny channels. This structural diagram maps the exact routing of that signal. The impulse propagates across the upper tissue via Bachmann's bundle to the left atrium, and down through the internodal tracts toward the center. As this electrical wave sweeps across the atrial tissue, It triggers their simultaneous contraction. On an ECG, this initial burst of electricity is recorded as the P wave. The impulse then hits the atrioventricular, or AV node. Because of the insulating fibrous skeleton, the AV node acts as the critical gatekeeper. It is the only normal electrical bridge connecting the atria to the ventricles. The AV node intentionally slows the electrical signal down. This necessary delay gives the ventricles time to fully relax and fill with blood before they contract. On the ECG, this delay is captured as the flat PR interval. Once past the bottleneck, the signal speeds into the upper interventricular septum through the bundle of His. It quickly splits into the right and left bundle branches to route the current straight down to the apex. The current finally hits the Purkinje fibers. These fast-conducting tissues distribute the charge instantly, triggering a rapid, synchronized upward squeeze of the ventricles. This massive electrical discharge creates the sharp QRS complex on the ECG. The electrical grid perfectly dictates the mechanics. Cellular depolarization translates directly into the coordinated physical squeeze required to generate forward stroke volume. Before the heart can pump a single drop of blood to the rest of the body, it must feed itself. The coronary arteries branch off directly from the aortic root, positioned immediately above the aortic valve. The left main coronary artery divides almost immediately. It splits into the left anterior descending, or LAD, which supplies the massive anterior wall and the septum, and the left circumflex, which wraps around to feed the lateral wall. The right coronary artery, or RCA, supplies the right atrium and right ventricle. Crucially, in the majority of people, the RCA also provides the primary blood supply for both the SA and AV nodes. The specific branching pattern of these vessels determines coronary dominance. Whether a heart is considered right, left, or codominant depends entirely on which artery extends to supply the posterior descending artery at the back of the heart. This vascular network operates under a unique mechanical constraint. Unlike the rest of the body, coronary perfusion reaches its peak during diastole, the relaxation phase when the ventricles are filling and the aortic valve is closed. When the heart enters systole, the pressure of the contracting myocardium physically squeezes the coronary vessels buried within it, halting their blood flow. The entire electromechanical architecture, the spontaneous pacemaker, the synchronized conduction pathways, and the sheer muscular force relies absolutely on continuous flow through these fragile fuel lines. When a clot forms in one of these vessels, causing an ST elevation myocardial infarction, or STEMI, the resulting failure is entirely dictated by the local anatomy. If the right coronary artery is occluded, the SA and AV nodes lose their oxygen supply, predictably resulting in profound electrical failure. This manifests as severe bradycardia or complete heart block. Without the electrical signal to drive the heart rate, the cardiac output equation breaks down. This specific electrical failure translates immediately into systemic hypotension for the patient. An occlusion of the LAD is clinically termed the widowmaker. Cutting off flow to the massive anterior wall and the interventricular septum causes extensive tissue damage and catastrophic bundle branch injury. The immediate loss of that massive left ventricular muscle means the main perfusion pump fails to generate systemic pressure. The result is rapid, profound mechanical failure and cardiogenic shock. A lateral occlusion of the left circumflex artery can extend ischemia to the posterior wall. If the papillary muscles anchoring the mitral valve are starved of oxygen, they can fail under pressure, causing sudden mitral valve regurgitation. The system follows a rigid logical sequence. The physical structure routes the perfusion. That perfusion fuels the electrical grid. The grid forces the mechanical squeeze. A myocardial infarction is simply anatomy deprived of oxygen. Mastering this electromechanical blueprint is the only way a clinician can see past the surface symptoms and anticipate exactly how cardiac output is about to collapse.